Hey everybody, so today we're going to be covering chapter 39, going over geriatrics. In this chapter we will discuss what effects aging has on the individual body systems, go over some findings that are specific just to the geriatric patient, as well as how do we assess the geriatric patient. Now, the geriatric patient, due to the various issues that arise and the effects that aging has on the body, it does place them at a higher chance incidence of injuries as well as illnesses because of effects on the musculoskeletal system, the integumentary system, their immune system, so on and so forth. They're also more likely to be having multiple comorbid conditions that will require them to have multiple medications. There are many times where we show up to a patient's house and we ask them for their medications, and they pull out a box that has like 15, 20 medications contained within. And that tells us right there that this patient does have a lot of medical issues that we need to be aware of. And it affects the way that we treat them as well. Now, your body begins to break down around 30 years old, where you've basically reached your plateau, and now it's a slow, steady downhill trend. However, thanks to advancements in technology as well as pharmaceuticals, patients are now able to live much longer lives with illnesses that once would, if they fell victim to it, would be a death sentence, such as congestive heart failure. They didn't have the medication to diuretics or CPAP, and the patients would literally drown inside of themselves. They also, because of the aging body, their reserves where they are able to compensate for severe medical or traumas are fewer in number. So they're not able to compensate for various issues as well as they were 5-10 minutes prior. As their heart continues to grow older, within the cardiovascular system, if you remember, there are pacemaker cells within the heart that helps ensure that the heart is pumping at a regular rate. Well, as they continue to grow older, these pacemaker cells or electrical conducting cells become less and less. So that the heart is less responsive to the catecholamines within the body. This prevents the heart from increasing its rate when a greater cardiac output is now required. The patient may also have fallen victim to what's called cardiac hypertrophy, where the left ventricle, which is the one more commonly to suffer from this, becomes bigger and bigger due to overstretching to now it can't fully return to its size. So now it's bigger than it should, and it's not able to push blood out as well as it used to. You also have stenosis of heart valves, where the valves have become hardened to where now they're not able to open and close properly as well as they used to. Just as all other muscles within the body contract in response to electrical impulse, the heart muscle contracts in response to electrical impulses created by the conduction system of the heart. With aging, there can be a general deterioration within the heart's conduction system, thus resulting in the inability of the heart to initiate and propagate a normal impulse. You also have baroreceptors, which are what? What do they monitor? Correct. They monitor for changes within the blood pressure. These are now less sensitive, so now when the patient goes to shift positions, the body's not able to compensate for it. Thus, orthostatic hypotension is more likely to occur. Within the geriatric patient, there's also a decline in diffusion of oxygen and carbon dioxide that it's able to move across the alveolar membrane as alveolar surfaces progressively decrease. Chemoreceptors located within the aortic arch and within the carotid bodies and on the surface of the brainstem that monitors the levels of carbon dioxide and oxygen within the blood also become less sensitive over time. Another change is the airflow in and out of the lungs. In a younger person, the smaller airways or bronchioles are supported by smooth muscle, which thus enables them to keep their open shape so that oxygen is easily inhaled with each incoming breath, and thus carbon dioxide is easily exhaled with each exiting breath. With aging, though, there is a decrease in both the number and strength of these smooth muscle fibers that support the smaller airways. The result is what's called turbulent airflow, which is diminishing airflow to the terminal alveoli during inspiration and can also result in air trapping during exhalation. You also have weakening of your cough reflex and a decreased function of the cilia that lines your trachea. So this also increases the risk of infection because now it's not able to cough out and get rid of dust and bacteria that you may have inhaled. Within the neurological system, the capability of the brain to monitor and regulate vital functions such as rate and depth of breathing, heart rate, blood pressure, and core body temperature can become deranged and not operate with the same efficiency during stressful times as within the younger patient. You also have decrease in brain mass, thus causing an increase in cerebrospinal fluid volume, which can cause the patient to become more likely to develop Alzheimer's and dementia as well. Sensory perception tends to diminish also over time, including everyday senses such as auditory, visual, smell, touch, pain, hot and cold sensations, as well as body positions. That's also due to the body position. Because of sensory perception decline, the patient is more likely to fall over because they're not able to sense exactly how they're positioned. You also have diminished vision and hearing, separately or in combination to cataracts or glaucoma, can easily result in falls, automobile crashes, and other causes of injury. Neuropathy is any derangement or abnormal function of the motor, sensory, and autonomic nervous tracts. It could be diffuse, involving multiple neurons and nerve tracts that affect many parts of the body, or focal neurons that affect a single specific nerve and part of the body. Findings could include pain, numbness, tingling and swelling, muscle weakness, or even absent pain perception. This can further complicate the presentation of finding characteristics to a specific problem. Within the GI system, because of degeneration of the lining of the small intestines, nutrients are not as readily absorbed, thus further contributing to malnutrition. Fecal impaction and constipation are also common because smooth muscle contractions of the large intestines are diminished. In some patients, degeneration of the rectal sphincter muscle can also cause loss of bowel control. Within the endocrine system, you have an increase in the level of hormones can increase blood pressure. Hormones such as norepinephrine and vasopressin, which are vasopressor hormones. This which contributes to the development of hypertension or high blood pressure within your patient. The levels of certain hormones that help regulate the body's fluid balance, such as renin and aldosterone, becomes deranged and contribute to fluid imbalance. which thus has further effects on your blood pressure. Collectively, changes to the endocrine system can cause elevation of blood sugar levels, alteration of blood pressure, as well as fluid imbalance. Within the musculoskeletal system, you have various changes occurring within as well. You have discs located within the vertebrae of your spine that begin to narrow, which causes the characteristic curvature of the spine, seen in 2 out of 3 geriatric patients, known as kyphosis. This curvature is seen along the entire spine, but is usually most pronounced within the thoracic vertebrae and can complicate spine motion restriction, especially if the patient is being secured to a backboard. Your ligaments, which provide joints with stability, also begin to weaken as well. The effects causes diminished range of motion, possible pain with movement, and an increased risk of joint injury. Within the renal system, because of a diminished kidney function, altered GI absorption, and as well as altered liver function, geriatric patients are more susceptible to toxicologic emergencies. Other factors that can place the geriatric patient at an even greater risk of a toxicologic emergency include poor eyesight, medication noncompliance, polypharmacy, loss of the integrity of the blood-brain barrier, and poor motor skills. The reason that they have that increased chance of toxicologic emergencies is because of the kidneys not able to filter everything properly. Drugs are not able to clear the body system as well. So they may take a pain medication and 6-8 hours later it's time for them to take some more. But because of the decreased kidney function, they may take the next dose again. Well, because the previous dose hasn't fully cleared, now they may have overdosed on it. As the skin continues to break down, there's a tendency for sores and tearing injuries to occur. This diminishes the effectiveness of the skin as a protective barrier in keeping microorganisms out of the body. Also, skin is a major organ of thermoregulation. Therefore, hypothermia and hyperthermia are more likely within the geriatric patient. The patient or EMT may underestimate the severity of the patient condition. You, as the EMT, must recognize these emergencies and provide appropriate emergency care. Also, because of the various issues that they may have going on, the pain that you would normally assume that would be there may be diminished or absent. For example, with a heart attack or myocardial infarction, instead of the patient presenting with the stereotypical sharp stabbing chest pain that you would normally see with a patient having a heart attack, they may not have any at all. And they're presenting with what's called the silent heart attack, where they just feel weak, fatigued, or confused. Maybe have some abdominal pain or syncope, nausea or vomiting. That's why any patient that is complaining of weakness or abdominal pain, dizziness, trouble breathing, syncope, nausea or vomiting, definitely in the geriatric realm, go ahead and knock out a 12 lead. It's not going to hurt them. Go ahead and do it and rule out an MI. They may also complain of achy shoulders, indigestion. Trouble breathing is one of the most common initial complaints of a patient having a heart attack. Although 1/3 of geriatric heart attack patients never experience pain, they may still complain of the achy shoulders and indigestion, which is very common. Patients that have chronic chest pain may also be prescribed nitroglycerin. For patients that are prescribed nitroglycerin, make sure that you follow local protocols in assistance of the medication. Emergency care steps for a suspected heart attack is to administer oxygen via nasal cannula at 2 liters if the SpO2 is less than 94%. If there are signs of hypoxia, poor perfusion, heart failure, or if the patient is complaining of dyspnea, administer aspirin and nitroglycerin as appropriate in consultation with medical direction. And transport the patient expeditiously, but cautiously, to the nearest appropriate facility. Congestive heart failure, this can be either a new onset issue or a chronic condition. Congestive heart failure is caused by a weakened portion of the heart, thus causing blood to back up in certain areas depending on which side or which area of the heart is affected. If the patient has chronic congestive heart failure, this is something that they will tell you during your history taking. Or it can, if it's an acute onset, it could be the cause of the patient summoning EMS. And just because they're having chronic, if they have chronic CHF, does not mean that it could be exacerbated. CHF is primarily caused by cardiac disease, and it can present differently than that of a heart attack. It's caused by a heart that's become weakened over time because of the changes in aging, as well as hypertension, arteriosclerotic disease, dysrhythmias, as well as heart valve damage. The patient may present with jugular vein distension, peripheral edema, crackling upon auscultation, orthopnea, tachypnea, as well as chest pain. Emergency care for a CHF patient includes administration of oxygen to maintain an oxygen saturation of 94%, placing the patient in a Fowler's position, so that way if they have fluid in their lungs, it puts all of it down in the base, and expeditious transport. Be sure to watch for inadequate breathing and prepare to ventilate the patient as needed. Shortness of breath or dyspnea. This is another common complaint that we will see. And this can be caused by pulmonary edema, pulmonary embolism or PE, pneumonia, as well as COPD. Breathing can easily become inadequate if not treated aggressively. Pulmonary edema or fluid in the lungs can have a gradual or even sudden onset and can result in death if proper emergency care is not provided. Pulmonary edema is ultimately caused when the left ventricle is no longer able to eject blood properly. So the heart's still getting blood in, it's still getting the proper amount in. However, there's not enough getting out, so now we have an issue with the afterload. So now the blood is beginning to back up within the lungs. As this continues to occur and more fluid continues to dump into the lungs, now the fluid is beginning to leak into the space between the alveoli and the capillaries, thus causing gas exchange to become adequate. The patient then becomes hypoxemic and eventually hypoxic. Patient will present with orthopnea, possibly blood-tinged sputum, severe respiratory distress. Care of these patients includes administering oxygen to maintain an oxygen sat of 94%, placing the patient in Fowler's, monitoring for inadequate breathing, and transporting expeditiously. You can consider administration of CPAP or continuous positive airway pressure if the patient is in severe respiratory distress or if an SpO2 cannot be maintained of 94. Pulmonary embolism is caused by a blood clot that is broken free, usually within a vein of the lower extremity or pelvis, and is then transported back through the right side of the heart, eventually reaching the pulmonary artery. A large enough clot could also prevent blood return to the left side of the heart, also resulting in hypotension. These patients will present with sudden onset of dyspnea, possible back or shoulder pain, anxiety, weakness. With large clots, the blood cannot make it from the right side of the heart to the left, and hypotension then ensues. You might also notice localized wheezing to one of the lungs, and with blockage, your pulse ox may drop dangerously low. If a large embolism occludes more than half the pulmonary circulation, it can also cause a rapid death. Treatment of these patients is maintain an oxygen stat of 94, positive pressure ventilation if breathing is inadequate, expeditious transportation, and ALS intercept if possible. Some factors that could predispose you to a pulmonary embolism include aging, smoking, cancer, fractures, recent surgery, cardiovascular disease, prolonged bed rest, as well as major trauma. Pneumonia is caused by either some type of bacterial, viral, or fungal infection of the lungs. You can also have what's called aspiration pneumonia, which is the result of accidental aspiration of food or vomit into the lungs. This is why preventing aspiration of foreign material is so important in the maintenance of the geriatric airway. Pneumonia tends to strike with multiple risk factors are present. Some of these include advanced age, being bedridden at home or institutionalized, immune system compromise, history of pulmonary diseases, cancer, stroke, or history of inhaled toxins. Emergency care is pretty much supportive and includes maintenance of the patient's airway, administration of oxygen to maintain an O2 stat of 94, and transporting the patient in a Fowler's or position of comfort. COPD is a disease complex that includes many individual pulmonary disease processes, principally chronic bronchitis and emphysema, thus results from the gradual deterioration of the pulmonary structures. These patients may have oxygen that they use at home, and when they are calling because of a COPD issue, they're usually going to present in severe respiratory distress and use of their accessory muscles. We want to transport these patients in a position of comfort because the COPD patient can become easily fatigued due to the effort of breathing. We want to monitor the patient closely for signs of inadequate breathing. If their breathing does become inadequate, so provide positive pressure ventilation with supplemental oxygen. If they have an inhaler, we want to make sure that you follow local protocols and to assist the patient with its use. If you're unable to maintain an O2 stat of at least 94%, you can also consider administration of CPAP. Altered mental status can be caused by a multitude of different things. It can be chronic, could be new onset, could be chronic such as Alzheimer's, or they could be having a stroke. Just because they have altered mental status, do not assume that this is normal for the patient. Talk to family. See if you can figure out what's going on with them. Cognitive impairment is any kind of deterioration of the patient's ability to think, their ability to remember, recognize things, as well as language and judgment skills. Severe cognitive impairment can cause the patient to lose their ability to understand the importance of something, as well as the ability to talk or write. There's higher morbidity and mortality associated with an impaired cognitive state. Therefore, it is very important for us as EMS to identify the patient's condition. The key in emergency care of these patients with an identified cognitive impairment is to ensure that they can take care of themselves or in an environment in which adequate resources are available to take care of them. Stroke occurs when there's an interruption within blood supply to an area of the brain, when a blood vessel in the brain becomes blocked by a clot, obstructing blood flow, or ruptures and enables blood to accumulate within the brain tissue. Ischemic is that's caused by a clot, hemorrhagic due to a bleed. During the process of a stroke, you may also have increase within intracranial pressure, and that's when you may have thus results in the altered mental status that ranges from just simple disorientation to completely unresponsive. The signs and symptoms that you will see depends ultimately on the extent and location of the stroke. The patient may present with unequal pupils, headache, abnormal heart rate, altered respirations, memory problems, sensory loss, muscle weakness, seizures, hypertension. If they have if they are having a massive stroke, it can also cause the patient to die within a matter of minutes. Treatment for these patients ultimately is recognition. So we're going to use what's called the FAST assessment to assess for it, where we're looking for facial droopage, arm drift, speech abnormalities, as well as time. We want to make sure that we're able to maintain the patient's airway, ensure that we can maintain an O2 sat of at least 94%, have suction at the ready, and transport the patient either in a Fowler's position if they are conscious, or lateral recumbent if they are unresponsive. TIAs, or transient ischemic stroke or attack, does not cause any permanent neurological dysfunction. TIA is caused when blood supply to an area of the brain has become temporarily occluded, thus causing a malfunction of brain tissue that is not being perfused. However, even though it is not a true stroke, because we cannot differentiate it within the field, because the signs and symptoms can resolve in up to 24 hours, we treat it the same. Ultimately, they won't be able to tell, ensure that it's not a stroke until they get them to the hospital and can do a CAT scan. If it is a TIA, it's often a precursor for a full-fledged stroke. Seizure is caused by any sudden is a sudden and temporary alteration in mental status caused by a massive electrical discharge in a group of nerve cells within the brain. Seizures can be caused by can include cardiac arrest, tumors, trauma, infection, low blood sugar, or even an electrolyte imbalance. Treatment is the same as you would for any other patient. Just monitor their airway. If they are no longer seizing and they are still unresponsive and trauma is not suspected, you can consider placing them in the recovery position to prevent them from aspirating. If the breathing is inadequate, provide positive pressure ventilation, and if it is adequate, provide oxygen to maintain an oxygen sat of at least 94%. Syncope is a temporary loss of responsiveness that usually once the patient lies down quickly reverses itself. This is very common within the geriatric patient due to issues with their baroreceptors. If the patient has fallen, you do need to consider providing spinal motion restriction. For these patients, you want to make sure that you are able to maintain an adequate airway, maintain an O2 sat of at least 94%, provide ventilation if their breathing is inadequate, and if they are unresponsive but breathing adequate and no injury is suspected, place them in the recovery position. Hyperosmolar hyperglycemic syndrome is a diabetic complication that's more common within the geriatric patient with diabetes mellitus. What is occurring is as their blood sugar continues to rise, there's still insulin present that allows for glucose to be used for energy so that ketones are not being produced. However, they still have the P's: polyuria, polydipsia, polyphagia. With these patients, they're usually going to present with a gradual onset of altered mental status, possible history of diabetes, as well as an elevated blood glucose level. Usually, I'll be honest, when you go to check their CBG, is probably going to read high. Ultimately, for the management of these patients include managing the airway, maintaining an SpO2 of at least 94%, and you can also consider an ALS intercept. Alright guys, we're going to take a break here. When we come back, we'll pick up with drug toxicity. So get up, stretch your legs, get something to drink, whatever you need to do, and we will be back shortly.